Hi, everyone, and thanks for joining us for this session, Pandemic Review and Planning, Moving Forward by Looking Back, presented by Point Click Care. Your speaker today is Jayne Warwick, also with Point Click Care. Take it away, Jayne.
Hello, everybody. I'd like to welcome you to Pandemic Review and Planning, Moving Forward by Looking Back. My name is Jayne Warwick. I am the Senior Director of Medical Records Compliance for Point Click Care. Next slide. I'd like to start with a couple of disclaimers. The first one, the information and direction about COVID is constantly changing. It's changing on a daily basis. So the information in this deck is current as of the recording date. And I'm also not an expert on COVID epidemiology or public health. However, I am a registered nurse who actually went through the first episode of SARS back in 2003. I'm also part of Point Click Care. So a lot of our customers have reached out to us. So this deck includes some of the experiences I learned back in 2003, as well as information our customers have brought to our attention during this round of COVID. Upon completion of this session, attendees should be able to understand and develop relationships to assist with the prevention and management of COVID-19 cases, to be able to implement strategies for managing resident care in accordance with their wishes, to develop and implement strategies for communication to all stakeholders, and to review and determine resourcing plans for potential future waves of COVID-19. So first, I thought I'd level set the conversation with some characteristics and statistics around coronaviruses in general. Now, coronaviruses are not new to us. They were first identified back in the 1960s, but they've been around a lot longer than that. They're actually named for the crown-like spikes you see all over that picture in the middle. That's an actual coronavirus virus there. There are four main subgroups, alpha, beta, gamma, and delta, and the genetic material is stored in the RNA, or the ribonucleic acid, and that makes it similar to the flu, which is also an RNA virus. It's widely infectious in many species. So coronaviruses, the alpha and beta versions, sorry, are infect mammals, including humans, while the gamma and delta species infect birds mainly, but not exclusively, and they occasionally infect swine. All coronaviruses have their origins in warm-blooded vertebrates. Alpha and beta come from bats, and the gamma and delta variety come from birds. And randomly during replication, copying mistakes occur, and we have mutations. And that's exactly what happened with COVID-19. Next slide. Well, there are 7 known coronaviruses out there currently. 4 of them commonly infect humans, and they cause about 30% of common colds. The other 3, SARS-CoV, MERS, and SARS-CoV, the new one, those actually jumped to humans through animals. So the first SARS back in 2003, it went from bats to civet cats to humans. MERS out in the Middle East, that actually went from bats to camels to humans. And then COVID-19 went from bats, and it's suspected it jumped to pangolins, which are an armadillo-like creature, and then to humans. Now, with COVID-19 in specific, this is what we call a novel coronavirus. And the word novel applies to the fact that there's no known natural immunity or inoculation for this particular virus. It is a spectacular spreader. There were already 2 strains evident out there. We saw the D strain or the Asian strain came in through the West Coast, and then the G strain or the European came in through the East Coast. The R0 value, which is actually the same as an infection rate, but for a novel virus, we call it an R0, or the average number of people infected by one person, for this particular disease was quite alarming. So if an R0 is less than 1, there's no spread. If an R0 is equal to 1, we can control the spread. But if the R0 is greater than 1, then the spread must actually be managed. Now, in the 1918 Spanish flu, the R0 was between 1.4 and 2. So every infected person infected at least 1.5 to 2 other people. In 2009, the H1N1 virus, that had an R naught between 1.4 and 1.6. But with COVID, back in the early stages of this disease, the median R naught was 5.7. And the strain that went in through New York and the East Coast was actually more infectious than the D strain that went in through the West Coast. Even though the morbidity and mortality rates overall were the same, the actual amount of infections and costs were quite large in New York. Part of that was the geography. It's a very vertical city, and the rest was just the type of virus that came in and the strain. Next slide. So as of August 24th, they had kind of gone back and looked at the infection rate with COVID, and they determined it's still between 1.5 and 3.5, and that's with social distancing and mask usage. So seasonal flu is about a 1.3, Ebola was 1.5 and 2.5, SARS, the original one, was 3.0, MERS was between 0.42 and 0.92. So you can see that this particular coronavirus is, like I said, a spectacular spreader. It's got a real reach out there in the community. And the deaths from coronavirus have been quite alarming. So when we look at this point in time, which is September 19th, the total number of deaths were about 180,000, but the inpatient health setting accounted for 65% of the deaths. Nursing homes and long-term care facilities represented about 21% of the deaths. And that's a unique number because we house about 0.6% of the total population. So we had 21% of the deaths in a very small percentage of the population. 3% of people died in an outpatient or ER setting, and then 5% of people died at home. But the notable statistic here is that 52% of the deaths were in people 60 years old and 60 years of age and older. Now with COVID, which is very different than MERS and SARS, the data indicated that only about 1 in 10 positive asymptomatic people is getting tested. And that's really important because 40% of cases that we're currently seeing are asymptomatic. So the assumption is that there's a lot of people out there not getting tested that are actually infectious and spreading the disease. And we know from our current contact tracing numbers that 50% of spread seems to be asymptomatic or pre-symptomatic. So people don't actually know where they got it because they never knew anybody that had the infection. Of those that do get infected, 80.9% of infections are really mild, kind of cold flu-like symptoms. But 13.8% are severe, developing severe diseases like respiratory and cardiac problems. In 4.7% of cases, they're critical, need long-term hospitalization, and then 2% of reported cases are actually fatal. We know that the risk of death increases with age, race, and gender. In fact, what we're seeing in North America is slightly different than what we saw in Europe. So in North America, we're seeing more women die of the disease than males, but then again, in long-term care, females represent a higher percentage of the actual occupants. We do know that some pre-existing conditions increase risk, such as cardiovascular disease, diabetes, and chronic respiratory disease, hypertension, and obesity. And this is particularly noteworthy for us because those disorders are highly prevalent within the long-term care population. Now, pre-existing conditions that are extremely common in our residents, such as cardiovascular disease, diabetes. You can see from the slide that within the COVID population, there is quite a significant increase in the death rate. So we do see that the presence of any one of these diseases increases the risk of morbidity and mortality. Next slide. Now, there's a couple of other things that I want people to think of as we talk about this. There's been some kind of issues that arose during this time frame, not really issues so much as we highlighted problems out there. First was necessary PPE was not available or confiscated. So it makes it very hard to control the spread when you don't have the right protection in place. And there were numerous reports of homes having PPE confiscated by federal agencies or stolen from facility storage sheds or from delivery vehicles. In fact, one home actually reached out to us and they had their PPE stolen right off the tarmac. And when the people they'd ordered it from, they spoke to them, they said they actually thought they had hired security to protect their PPE. So these were things we'd never really considered before in actually protecting ourselves and our residents. This situation also highlighted chronic understaffing. Some homes have 75% of their staff off on quarantine or isolation. Additional funding support was slow to arrive. And so when you have that number of staff, you're really stuck on what to do. The physical plant limitations for asymptomatic spread, we have very narrow hallways, combined dining, and the limited ability to actually create enough isolation rooms to deal with the number of residents that were infected. And testing is actually required to find cases because of the asymptomatic spread. Screening alone is not enough. And initially, the tests provided to long-term care were faulty or not reliable. In fact, Nevada just pulled 2 of the tests that were provided to them from circulation because the false negative tests were too high, which has kind of left us here, right behind that coronavirus 8 ball. So that's led us into a place where we really need to start thinking about the types of relationships we have in order to manage this disease. So when this started, we had very few experts and resources emerging out of there, but we're now starting to see those people arise. We need to consider what help you need for the next wave if you're not already in it, and start reviewing kind of what happened in the past few months. You need to know what partners you can have out there that can help you with and what they can help you with. And you need time to improve relationships, so start working on those now. And you should focus on your upstream providers, public health, your vendors, your state agencies, and your associations. Now, when it comes to upstream relationships, what you really need to do now is start connecting with those people and finding out what their requirements are for testing on their end. You need to know when those residents last got tested and when that report will be available. You also need to be telling them what your criteria is for closing your doors to new admissions. Do you actually have criteria identified, and who provides those updates to your upstream providers internally when you need to close your doors? Where can you find their case counts? That's part of your risk impact. You don't want to be taking in more positive or suspected cases than you actually have the staff or the ability to take care of them with the isolation rooms you need. So being able to determine those resources in advance and inform those upstream providers is really helpful. Now, with public health authorities, we know that we've got a lot of data collection requirements coming, so you really need to determine who's going to be responsible for that data collection, how they're going to get that information, what they need to do with it, and who they need to send it to. And where do you also get the most up-to-date coronavirus information? So it's not just about the data you need to report, but what information do you need to stay as up-to-date as possible on what those trends and changes are? What measures are public health taking to track, for instance? Are they just testing people, or are they also doing things like some innovative areas where they're testing sewage and looking at effluents for the presence of denatured COVID, in which cases they can then go in and test or target those communities? How will the data be used to make decisions? What is the analysis and the outcomes, and how do you determine your risk for closing down your doors to admissions, for example? And what data is actually pertinent to you? So studies have shown that the highest risk to facilities exists when there are actually COVID cases in your county. There have been several studies that have shown this, including one that was done by Brown University in Genes and presented at the impact rounds. They found that county cases were quite significant in the risk to the facility. So the most likely predictor of COVID in a nursing home was county cases that were there. And this is an example of a tool that you can actually use in planning or determining your risk in an area. So this is a tool from Georgia Tech. It takes all available information out there. And you can see there's a little slider there that says event size. And you can adjust the slider and it will tell you the probability that somebody with COVID would show up in a group of that particular size. So on the screen there, it says Lee County, North Carolina, and there's a 14% risk. So if you have 10 people in a group, there's a 14% chance that at least one of them is infected with COVID. And these numbers are very helpful. First of all, you can share it with your families and your residents. This has become my new obsession, looking at this tool. But you can use it to help inform yourselves as to the risk for when you open up your doors or even choose to close them. Next slide. Now, your software vendors, people like me, we had the benefit of being able to see the forest for the trees. So we became a source of information for waivers and setup changes and new guidance for data submissions, how to get that information where you needed to get it. We're definitely the source for best practices with your tech, and we can provide assistance with things like infection control, getting the data you need, the devices you need to manage your infection control, contact tracing apps or APIs that are available, help with learning for new staff and onboarding. That became a real issue during the first wave. And then communication software. How do you get notifications and updates out to your staff and families? Your vendors are very helpful in that respect, and you should continue to develop those relationships. At the same time, you need to start identifying who are the people you need to connect within your state agencies. They'll also need data for CMS, CDC, and state health teams. It could be the same person that's collecting your public health data, but make sure you're clear on what data needs to go where. You need to seek regulatory guidance and expertise in advance. So you can go back and look at the many waivers that were released through the first wave and understand how the application of those waivers needs to be presented in your home. And do there need to be changes to your tech in order to activate or best suit your setup in order to move forward with the waivers, especially around reduced administrative burden. There's also innovative ideas to support care that you may need to seek approval for from state agencies. So a couple of things that came up from clients that we engaged with, one had set up care buddies. So they had cognitively alert residents looking out for residents that were less alert, checking in on them, making sure that they were okay. Self-reporting. So they had residents, again, cognitively alert, that got set up on their POC devices so they could actually do their own screening on a daily basis. And staff knew then that they were okay and coping. And the other thing that you can concentrate on are staffing bubbles. So partnering with or between communities or facilities in order to expand your available staff. So instead of exposing the risk and having people go to multiple homes, you can say, we're just going to share staff between these two homes, and that's going to be our COVID bubble. And that reducing administrative burden, especially at a time when we were so busy, you need to get that information up front. Documentation requirements for staff and physicians under COVID. What are the data collection minimums that you need to maintain? Is it just symptom checking, or should ADLs be collected? Things like that. And not just about care communication, it's about legal documentation as well, because a lot of us will find ourselves in a position where we're defending the documentation and the care we provided during this time frame. Now, when it comes to associations, just like the one that is putting on this particular conference, they're really good at lobbying on your behalf. They have a really good picture of what's going on in your region. You can connect in with them and they can provide feedback on where you are struggling, because they will also have that information from other people in your area. And like I said, they advocate on members' behalf when they start to see commonalities and struggles that they need a shared solution for. People focused on new regulations, acts affecting care and service provision exist in every association, so they're always looking on what changes can be made. And they can work with vendors and state agencies to review and interpret data on your behalf. They also provide education, just like this one, support, and they also, most of them have listservs, which are not only moral support, but they also offer implementation strategies, staffing resources, PPE sources, things like that are being shared on those particular vehicles. And you should engage with them as much as possible to leverage the advice and the information. All right, let's talk a little bit about managing resident wishes as well as their care during COVID. So one of the biggest problems that came up time and time again was the adherence to understanding and really carrying out residents' end-of-life care wishes. A lot of homes were not prepared to have the level of frank conversation with families and residents that they had to have, and they found themselves scrambling to document cultural and religious preferences for end-of-life care. We've never been in a position before where, if something got into your facility, a number of residents were expected to die. So that was really stressful, not only on our residents and our families, but also on our staff. It would really help to have clearly identified code status for an emergency identified on every chart, whether they're a code or a no code, just straight up what we need to do. And also make sure they're clear on understanding the difference between immediately resolvable issues such as choking versus COVID pneumonia, for example, which is not resolvable without invasive intervention. Make sure it's visible on all charting areas and staff are really clear on who receives what assistance and how to get that assistance, and that there's a clearly defined process for both a code and a no code internally, and you may have done some practices. It's not only important to your residents to respect their wishes, it's also important to your story and it's relevant to your statistics. If you don't have a really good understanding of what your resident wishes are and you don't have that clearly documented, you can't speak to that. And a lot of times residents died in our facilities because that's what they wanted to do. They did not want to go to the hospital. So having that clearly documented does become part of your PR and your story. Now, the secondary part to that is if somebody does go to the hospital, you want to make sure you have clearly documented advanced directives and decision makers. So not only does that make it easier on everybody if you know who to speak to, but you have clear lines of communication and it removes the burden on staff to communicate to multiple parties. And these really direct what happens if that resident goes to hospital. If the CPR is successful or they survive no CPR, what are the next care steps? Do they really want to be intubated or on a ventilator? Do they want IVs and IV medications, or is it strictly around comfort measures? You need to understand that. We need to be respecting their wishes, and having those clearly documented in advance of an emergency is really helpful to both you and the residents, so they're not making last minute decisions that may be impacted by their state of mind, which is right now in a panic because they're in COVID, rather than a rational, thoughtful process that they entertained these decisions. Next slide. So the other thing is you need to support your staff through this. It's unusual times and they're taking on more than they usually did, and they're really stretching their skills. So not only their communication skills, but are just flat out nursing skills and social emotional empathy skills. You may have to do a gap analysis if you notice that there were skill gaps identified during the first wave, and make sure you have the right equipment and the right internal support, such as those code practices going. You need to be transparent with families and residents about the risks and the resources you have in the facility, and be honest about those decisions, like what would happen if somebody goes through a full code? What are the risks to that individual? And you need to get staff comfortable with those difficult conversations. They may find themselves having to advocate for a resident who's previously made these decisions, even when the family no longer believes that that is the best approach. All right, let's talk about communication strategies you might need to entertain too. So for your staff, these are really uncertain times. There's a lot of fear of the unknown, and your role really becomes that voice of reason and calm. So you need to determine what you're going to communicate and how often with your staff. So, and I would engage with them and ask them how frequently do they want to be communicated to. The types of things you may consider for that content is like new information on COVID, new information coming out from regulatory bodies, case counts. When it comes to case counts, I would stick to county and facility. You want to keep the numbers as small as possible. They're less overwhelming. And what's only meaningful to you is what's happening in your immediate geography. What's happening overall in your state or your country is not as important as what's happening in your county and your community. You want to communicate any updates to policies and procedures as you start to build out more specific emergency planning. You want to make sure any isolation updates are provided. So who's in isolation, who's coming out of isolation, and PPE status, because we know that we kept running out in the first wave. What did they have to do to get new PPE? Are they reusing PPE? What types of policies and practices do you need to have in place? The other thing that you're providing through this is emotional support. You're being present, transparent, and empathetic in your communication, and that will help you with staff engagement. It should alleviate some of the feelings of being overwhelmed. It does provide opportunities to vent, which they may need in order to really just let something out, because we've been going through so much with COVID. And you need to assess the staff mental status and need for downtime. That's a really important thing, because they're getting burnout at this time is not helpful to anybody. Next slide. Communication to residents. So again, let them determine the content and the cadence. The case counts here, I would stick very strictly to the actual facility. You want to update them with precautions and visitation policies and any changes that are occurring there. You want to be transparent. You want to be rational and provide them with data. The communication should also include things like changes to activities, social groupings, and dining. And vaccination reminders are really important because while we have COVID going, we want to make sure we're excluding flu and the pneumonia with those two particular vaccinations. And then we added shingles on top because anytime that there's a stressful situation for people, shingles can be activated. So if they haven't had a shingles vaccine, it's a good idea to get that suggestion and done. Inbound communication, have a process. So if you have buddies set up between your residents, they can do wellness check-ins with you. And how do they manage that? Contact tracing, if they go out of the building, who they've been in touch with. Let them voice any concerns. And then how do they actually report their own symptoms? How do you inform of them what to look for, and how do they report the new onset of any symptomology? And then your families. In this particular case, I would set the cadence and then review the response to that cadence and adjust it as necessary. Your primary role here is to be the trusted advisor, provide transparency and openness, which will lead and hopefully build more trust between your families and yourselves. You need to communicate what to expect. Determine the method for comms. In this particular case, you may need to have multiple methodology. You may have to, put something up on your website, send out an email. You may even need to resort to voicemail depending on how people receive information and what's best for them. You need to provide a basic level of education to level set knowledge because there's a lot of disinformation out there. Providing information like the information at the front of this deck, for instance, what's common with coronavirus, really helps level set information so you can have educated conversations with families. Case counts for them, I would provide them with county case counts as well as facility case counts. And remember, transparency does not mean you're divulging private information here. So we're telling them numbers, we're not telling them people. You need to be clear on any visitation policy changes and provide them with the rationale, and also maybe provide them with the vaccination reminders, especially around flu, because visitors coming and going out of your facility, you don't want them bringing in flu either. One of the things you might want to consider is your admission contracts. You might want to include criteria for closing doors to visitation during an emergency. What will replace visitation and how, and preparation for such future circumstances. So a lot of homes were taken aback by the fact that the doors were closed to visitors, but if you put that into admission contracts and get people to acknowledge kind of why we're doing these things, it may prepare them for those eventualities. Slide. And then communication, really, this is your public persona. You need to control the narrative. One of the things that happened with COVID that I haven't seen in a long time was such negative press about nursing homes. And really what that came down to is a total lack of understanding of what we do, who we are, and how we provide care. Not only that, without having really clear information on COVID, we got blamed for the disease getting into our homes and spreading when it was an invisible enemy. We couldn't see it in the first place. So update your website regularly to inform the general public, engage in press releases, get experts involved if necessary, designate an internal spokesperson, keep to pre-approved messages and short direct statements. You want things that are easy to repeat and so you can be consistent. If you're releasing data, provide an explanation. So we saw homes say, we've had this many people die this week from COVID, but there was really no explanation around there where we said we saw, 10 people die in house as their wishes required, and then 10 people went to the hospital and died. We're not giving that rationale. A lot of our customers are really old, and we kind of painted ourselves into a corner with these numbers when there was a really good explanation behind a lot of what happened. Educate to what you do. There's a poor understanding of what living in an assisted living or a nursing home means, for example, especially those of you that have SNFs and assisted living. There's clear rationale behind a nursing home but not behind an assisted living. So make sure people understand exactly what care provision versus service provision is. And so have a social media policy. Provide your staff with language for their posts. If it helps, you want to make sure you're controlling the narrative from within your staff as well as coming out of your doors. And be careful using communication tools that are not secure for person-to-person communication. A lot of people will say things inappropriately. You want to make sure that that's protected information. Next slide. And then contact tracing. I cannot tell you how important contact tracing is. It's important to resident staff and visitor safety. The required collection of data should be on entry. Have a policy. You mean to ask for their name, address. A lot of people didn't want to give their address, but if you get their county of residence, you can at least track their cases in that residence and ascertain some risk. Make sure you're getting a phone or an email. The county, like I said, is super important to risk. And the county of visitors can identify the risk of somebody bringing it in. So if you see that they're coming from a county where there's a lot of cases, we can start to restrict visitation. It's also necessary to communicate risk and impose more specific visitation criteria. If we know that there's positive cases internally, if we're not contact tracing, we can't talk to exposure. Also signed attestation. So when you get people to fill in their information, get them to sign that they'll agree to wearing a mask, social distancing, washing hands, and reporting positive status if known. I've seen homes create really good forms that are signed that become that attestation statement for that visitor that they're agreeing to do these things. And if they're not willing to do those things, they can't come into the home. So let's talk a little bit about the types of resources we need to make sure we have on hand. So the first thing I want to talk a little bit about is COVID symptomology. There's a lot of misunderstanding about the progress that occurs with coronavirus. So what's the symptom progression? The first symptoms appear usually 2 to 14 days after exposure to the virus. So from the very first minute they're exposed, if you're going to develop symptoms, and remember 60% of people develop symptoms, 40% do not, it's going to be within 2 to 14 days of exposure. So you really need to be able to understand kind of that flow, because once symptoms are there, we kind of have a secondary countdown. From first symptom to dyspnea takes about 5 days. So if a resident shows symptoms, you need to start tracking and looking how long before we start to see serious symptoms. From first symptom to hospital admission, 7 days. So if you start to see dyspnea by day 5, you should be preparing for hospital admission in a couple of days. And from first symptom to acute respiratory distress syndrome has been 8 days when occurring. So it's a pretty rapid progression within our population. The most common symptoms we see out there, about 50% of people have a cough and 43% of people have fever. Muscle aches in 36% of people, headache 34%, shortness of breath 28%, sore throat 20%, diarrhea, nausea and vomiting 20% and 11%, and loss of a sense of smell and taste in about 8%, and abdominal pain in 7.6%. Now, when you look at these, a lot of our residents cough and have muscle aches and complain of headaches and have shortness of breath already. So this really speaks to doing better assessments and making sure we're resourcing up front, and I'll talk a little bit more about that shortly. The less common symptoms seen in less than 5% of cases is a combination of sore throat, runny nose, and sneezing. And in fact, when you see those, and specifically sneezing, the most likely thing that you're seeing then is a cold and not COVID. So we still want people to not come into the home and spread, but they're less likely to be spreading COVID. The other thing to remember with the symptoms, in 75% of cases, cough, fever, or shortness of breath were the primary presenting symptomology, so we need to understand that as well. So this speaks to symptom management for your staff as well. Screening versus testing. So we screen a lot of people coming through the doors, but again, screening only catches symptomatic cases. So it'll catch, that 60% where we're actually seeing things as long as they're in a symptomatic phase. That doesn't mean that what that means is screening is not the be all and end all to identifying cases. You need to have policies for your staff outlining testing and the response when to quarantine versus isolation, for example. You want to encourage self-contact tracing. So where have I been? I keep a log, for example, if I'm going in and out of my aunt's nursing home, I need to know where I've been. difference between usual and new or worsening. So we kind of have to do a level set on what our own symptoms are on a regular basis. If you have allergies, it's that worsening that we need to look for. Self-identification and reporting is really important. So we need staff to actually tell us when they're experiencing these things, which means there needs to be a level of trust. And like I said, an understanding of what personal risk symptoms baselines are: allergies, postnasal drip, if they have immune disorders, if they have a usual cough, they need to know what's normal for them. We also want you to start assessing baseline symptoms and risk on admission with your residents. So it's used to determine the monitoring cadence and reporting of symptoms, but you want to know if somebody's short of breath on admission and they're COVID negative, that shortness of breath is something that's natural to that individual, so that we understand what the differences are between their symptoms from their disease process versus symptoms from COVID. You also need to identify those residents with the comorbidities that increase risk, so obesity, hypertension, cardiovascular disease. You need to actually flag those residents, because if they get sick, they're going to be more sick more likely. Other characteristics that increase risk is non-compliance. So residents with cognitive impairment or dementia are going to be less compliant with masks and hand washing than those that are cognitively alert. So dementia also places people at risk. And if you have somebody with COVID that has dementia and they're a wanderer, that's an even greater risk, because you really have to figure out how are you going to limit that person without actually restraining them, because we have rules around restraints as well. Things like vaping, though smoking seems to not increase risk. I have no idea why that is true, but it's in the literature. Vaping, on the other hand, does. So, you know, we've got all these people that we switched over to vaping to try and get them to stop smoking, and that has actually increased their risk with COVID. There are also some things we can highlight or look for within our resident population that decrease their risk. So the presence of a BCG vaccine, that tuberculosis vaccine, very common in Eastern European, Asian countries to have been given that vaccine. There are lots of studies to show that the presence of a BCG vaccine will reduce the severity and the mortality of COVID. In fact, it seems to prevent them getting very bad disease very well. Cognitively intact. If they're cognitively intact, they can self-identify, they can report their own symptoms, and they'll have better compliance with the actual measures that you're imposing. And it's really important that we manage these symptoms well, and that understanding of that baseline is so important to our staff and our residents for actually managing their health, managing the spread, and identifying where we really need to step in for our patients. Now, the other part of this is your staffing resource plans. So we want to make sure that you're planning for the worst case. What happens when the majority of your staff are off? What do you do? So in the example I gave earlier, there was a nursing home very close to me who I was doing a lot of work with. And they literally had 75% of their regular full-time staff call in sick, or they were off on isolation or quarantine, 75%. They actually had the gardener and the maintenance guy helping with resident care. So we need to think about that eventuality. This is not a disease that picks on one particular type of person. It picks on everybody. So how do you make sure you have the resources that you need? I would start cross-training all your staff to provide care and services. So get your activities people trained on how to do ADLs, for example. Train volunteers for where you need them now. So this particular organization had quite a group of volunteers, and they actually not only trained their volunteers to provide some assistance with ADLs, specifically feeding, mobility, getting them up and walking. They had them all signed up as casual employees, so that when the next wave came and we were locking to visitors and volunteers, those people then effectively became casual employees, and they would bring them in to provide assistance. This gave them an advantage by doing this now. They got them all oriented before the next big wave hit, but it's an opportunity now for our nursing homes to really look at how do I staff up in preparation for potential loss of staff. How do you accommodate documentation when you got all these newbies coming on board too? What are your minimum tech requirements? And if there aren't tech requirements, what do you do with the paper? So we have a lot of people coming on board that may not have knowledge of how to use your tech. Is it okay to resort to paper in the interim? And how do your policies and procedures back you up with that? A lot of times getting the right devices into the hands of people isn't possible, or they may not have a smartphone that can help them do things like point of care. So you may need to resort to paper. So you just need to be clear on what that looks like. Look for creative solutions with sanction of state agencies. I talked earlier about staffing bubbles. I'm trying to figure out where you can actually safely provide care and move staff around without opening up to too much exposure from potential COVID coming into your facility. And the most important thing you can do right now is really engage with your staff. Staff engagement's necessary, especially when when they get to the point where they're forcing them to make choices between a facility. You want to be their first choice. You want to be the home that they pick to work for. So make sure you're engaging with them now. It's a good opportunity in the lull between waves, if you're in that position, to sit down with your staff and ask them what worked and what didn't during the first wave, and where did they make suggestions or changes, and how do they see the integration of additional staff, especially if they're volunteers coming in, and how do they feel that they can manage that care. Really include them in those discussions. It's really going to help with the engagement with your staff and developing that trust, but also getting buy-in when you have to change your approach to care. You should be updating your emergency planning and pandemic responses right now. You want to make sure that your safety plan includes a review of PPE. You want to extrapolate your needs so you're prepared for the next wave. If you don't have enough PPE, what does alternate PPE use plan look like? Do you have somebody out there sewing for you now is basically what I'm saying. What's your stockpile look like? Who's maintaining that inventory? And again, staff testing, quarantine, and isolation standards, do you have that clearly identified so your staff know what to do in the different situations? Infrastructure plan, case management, your community capabilities. So if you're just a standalone facility, if you're part of a CCRC, if you're part of the chain, what differences do you need to, what things do you need to know from policy and procedure standpoint? And then where can you get the room that you need for cohorting and isolating? You need to make sure that you've got kind of a plan, because in some cases, homes have done a really good job of decreasing their census to open up rooms for isolation. And then the state came back in and said, we have too many people in the hospitals. You have to open up those beds and put people into them, which is going to leave you short of isolation and quarantining beds again. So you really need to think through what that's going to look like. And then an infrastructure plan for communication. What's your bandwidth like? Access to the bandwidth, security of your systems, access to tech for care documentation, device management, infection control. These are things we need to think about internally, about the stuff that we use on a daily basis, because that has to be cleaned and set up in between as well. You want to make sure that you're starting to think about policies that need to be revised or updated. So I had previously mentioned, for example, your admission documentation requirements, acknowledgement of the home's right to control access for resident safety. A lot of people were challenging homes. They told me, you never told me you could lock me out of the doors. Well, now's the chance to get that into an admission agreement, or to get an agreement out there into the hands of your family so they understand why you're doing that. What are the minimum documentation requirements? Again, get these into policies. Your policies are the things that your lawyers will also revert to for information on why there are gaps in documentation during a COVID outbreak or any other outbreak for that matter. So what is most important, and how do you ensure that you gather only what's necessary so that you're not taxing staff during a really busy time? Physicians documentation. A lot of homes found themselves stuck trying to get out-of-state practitioners to come in. Some regions got hit really hard, and they ran out of doctors. They were going to the hospital. So how do you fill those gaps, and what do you need to do? And if you are using out of state or practitioners from another group that don't usually work at your home, what do you need to do to get them in and documenting? Make sure your pandemic and outbreak communications plans updated, as well as how you're going to manage your census. So transfers out of the facility, where are they going, testing, contact tracing, and especially if you're one of those facilities that became a COVID facility and you need to transfer the people that are not infected out of your doors, how do you make sure you do that safely? And what type of process do you need in place? What kind of documentation would need to go with them? And what kind of information do you need to update families with to make sure that that's done safely? All right. So I covered a lot in a short time, so I'm hoping that you'll be able to absorb all of that, or at least go back and read the deck. But I'd like to summarize with the following. So when we look at COVID, it's not going around. It actually sounds very much like this is going to be kind of like the flu. Until we get a vaccine in place, we have to manage this through social distancing, mask wearing. They're as good as a vaccination in the meantime. COVID will probably eventually, this particular one will probably turn into kind of like a seasonal flu and come around throughout the years moving forward until we get some really good strategies in place. And, you know, even with flu, we are starting to see seasonal, we usually see seasonal outbreaks, but we're starting to see them out of season. So we had one here in Canada and Alberta in the middle of July last year, for example, and that's because of global travel. So we have to be prepared for these things happening at any time of the year. COVID was a really good example of that. Flu normally happens in the winter. COVID decided to hit us at the beginning of the winter and not to leave. So it didn't go away when the weather got warmer, like we see with most other viruses. So we really have to think about this as something we need to be constantly vigilant for. It's not something we can ignore moving forward. Without a vaccine, herd immunity is going to be hard to achieve. And even with a vaccine, it may be because a lot of people do not seem to be willing to take the vaccine initially. So we really need to continue these blunt control measures until we start to see some level of waning of this particular virus. They are blunt control measures, social distancing, masks, and small groups, but they work very effectively. You need to stay on top of community risk as well as individual risks. So we need to look at what's happening outside of our doors in our immediate county, as well as within our doors. And those county numbers are the only numbers that really matter outside of your community. So outside of your immediate local numbers, your county, and some counties are really big, that's why I'm wording it that way, are really what's important. You need to educate as well as inform your stakeholders. That's your job. If this wave of COVID has taught us anything, it's that no one understands post-acute care. I been doing this for 30 years, and I did not realize how little people really understood about what we do until this happened. Expectations of care often outweigh the reality, and this can be exacerbated in an emergency. So we really need to communicate well to families so they understand what it is we can do versus what they expect us to do, because we often don't meet their expectations because we haven't set their expectations in a way that we could meet them in the first place. So we have to really think about that. There's a lot of tough decisions that are going to need to be made. Keep good data at hand. It's important to supporting your decisions and getting people on side, especially when you have to close your doors to people coming in. There's still a lot more to learn in combating and dealing with coronavirus. We don't know nearly enough yet, and things are constantly evolving. So your staff need to be prepared for constant changes, because that's just the reality we're in. But utilize your partners to get where you need to be. Make sure you've engaged them and that you know what help they can provide and that they're willing to be partners through this process. And don't forget to take care of yourselves and your staff, because that's the only way you're going to take care of your residents through this process. So I thank you for your attention, and that's the end of my session.